Hello, everybody. We are live here on International Day of Radiology. We have still some soundtrack going on. Hello and good afternoon. My name is Dr. Kai. I'm a radiologist. I see. Sorry, I had some echo. That's hiccup small. Okay, so we are here today on International Day of Radiology, and I'm very happy that we can do this session today live and not as a recording. Today is the 130th anniversary of the invention of the X-rays, or of the discovery of the X-rays by Professor Röntgen, and it's my pleasure to have this live stream today with four experts of the field of radiology and who are specialized in artificial intelligence, which is the overarching topic today. So our first guest is Dr. Prina Agarwal. She's a radiologist currently working in Freiburg in the south of Germany. She did her medical studies in India and also the start of her radiological training, and then she came to Vienna in Austria due to a grant, and later on transitioned to Germany, and since then has had her scientific career over there. And she's specialized in pulmonary imaging, mainly. Of course, she's a general radiologist and knows about all parts, but pulmonary imaging is her special topic where she's an expert. And she has prepared a nice presentation about the use of AI in this field. So Prina, please share your screen and we will work it out. Thank you.
So thank you for the invitation, Kai. It's really an honor to be a part of the International Day of Radiology here online for all the people out there interested in this field. I will not call myself an expert because I think we are all gathering experience with this field, and whether we like it or not, we have to learn to deal with AI and learn to understand the nuances that come along the way and learn to interpret it in the best way we can in our clinical field. That being said, I'm really passionate about pulmonary imaging, and I'm going to talk about the role that AI plays in pulmonary imaging and focus on the current hot topic in Germany, that is lung cancer screening. Let me tell you a little bit about lung cancer. We know that it's the #1 cancer killer worldwide. And why is that so? Most of the patients who have lung cancer don't feel the symptoms unless it's too late. And when they do feel it, it's already too late. And that's the main problem. If you look at the lung cancer in this graphic, you can see that most of the patients who come with lung cancer come at an advanced stage. And if these patients would come to us earlier in stage 1 and 2, that is, then these patients have a better chance of survival just because the tumor can be just resected out. Compared to that in the later stage, it's difficult to treat these patients, and because of that, they have a less better chance of survival. And exactly because of this, we have a power of screening. Screening can cause a stage shift. That means that we can move the stages that we see to an earlier stage in patients. And I show you this beautiful image. This is from the study in Taiwan. In Taiwan, they have been having lung cancer screening for many years now. And you can see that over the years, there has been a stage shift. That means they catch patients at an earlier stage, and that is why they're able to save more lives. We know also from studies that lung cancer screening can cause a mortality reduction, a lung cancer mortality reduction for up to 20%. This is good news for Germany because finally lung cancer screening is legal in Germany since last year. And we're also expecting the medical insurance, the statutory health insurance, to cover it from next year. Now, let me walk you through. One of the most important thing here is this is the first time ever that it is legal. Lung cancer screening is legal, but it is also mandatory to use AI. And I'll walk you through the steps of the lung cancer screening. What happens? How do we do the lung cancer screening process? Now, because we cannot screen everyone for lung cancer, we screen high-risk patients. We know that cigarette smoking is associated with lung cancer. So we identify heavy smokers between the age of 50 to 75 years, and then these patients get a low-dose CT scan. Low dose because we want to keep the radiation exposure to a minimum. And these images, which are then acquired, are interpreted first by a radiologist and then by AI for nodule detection. And then the whole thing is characterized in a report with the help of risk stratification to decide in which way it goes. To summarize, in Germany, we are using the LungRAD system. And in a very simple way, we can say that when the patient has LungRAD score of 1 or 2, it's a negative scan, and the patient comes back next year. The success of the program also depends on these patients coming back, which means we expect to see these patients every 12 months. For unclear cases, we call them back in 3 to 6 months to see how fast these lesions, these nodules that we have detected, are growing. And for suspicious lesions, they would be directly worked up. And now we're going to look at how AI is going to help us in each of these steps. First of all, we need to acquire the CT scans. And beginning at this step, there are tools that help us with automatic patient positioning. And this is important because this helps to reduce repeat scans and keep the radiation dose low. Also, we have tools which help us in intelligent topogram planning. That means we make a topogram first and plan our scan. And very important in lung cancer screening, we are not allowed to miss any part of the lung apex, the lung base, because there might be tumor there, which we might miss. And we might have to rescan the patient and increase the lung dose. So both of these things help us in the scanning, in the phase of acquisition. Once we have the image, we know that the low dose scans are not as good as the normal dose scans, and they're a little bit noisy. And now we can either reconstruct them with the help of deep learning methods, which make the images much more nicer without losing the quality of the images. And there are also applications, for example, this one particular commercially available solution called ClariPy, which clarifies, in a way, the lung images and makes them less noisy. In this way, we can go down further with the radiation dose. And this is important because we want the patients to keep again and again. And there is always a cumulative radiation dose that the patient is going to get. And when we are able to reduce the radiation dose without compromising on the image quality, that would mean a lot for the patients or the candidates of the screening. Now let us move a little more ahead. Once we have the images, now we have to analyze those images. And now I'm going to show you some of the tools which are available and also walk you through the tools that we need to analyze these nodules. There are, at the moment, many different commercially available softwares out there, applications, and I can show you this particular website for all those who are interested. It gives us a list of all the solutions out there. We can filter them out based on the organ. I have filtered out chest. You can see whether they have a CE or FDA certification. And I'm going to show you some of the example here, which we use in our routine. This is a tool for chest X-ray. This is the patient with a primary cancer somewhere else with lung metastasis. We do see some of the metastasis here. But one can clearly see that with the help of AI, we are able to pick up much more nodules that we can see, which we can retrospectively identify. For example, this one, which is hidden behind the liver shadow. What do we need when we are looking at a CT tool for identifying lung nodules? Let me walk you through the workflow first, and then we look at some example. The first step is to detect the nodules, that we identify if there is a nodule in the lung. And then this nodule has to be accurately measured. How is it measured? With the help of these AI tools, we can measure the volume of the nodule, that's the segment. And this is very important because we know from our experience that two-dimensional measurements of these nodules are not very accurate, which then can affect downstream management decisions. Now, let me show you an example. This is an image which I made with Cloud AI, just to show that there's a nodule which is going from 5 millimeter to 6 millimeter over 3 months. We might not be able to really measure it on a CT scan, but clearly with the help of volume, we know that it's growing up to 70% and having a volume doubling time of 156 days, which means that this lesion is highly malignant. But stuff like this can be really missed if we're just measuring the lesions with our hand or the CT scan screen. And because we're able to measure the volume, we can measure the volume doubling time, which helps us to know whether a lesion is growing faster or slower, and also calculate the malignancy risk. Now, this is one of the commercially available softwares. It's called Coline. It can detect the nodule. It can measure the volume. It can tell you if it's a solid or a path solid nodule, and it can also tell you in follow-up if the lesion is growing faster or slower based on the volume doubling time, and can automatically assign a LungRAD score, which definitely needs a human oversight. This is another example of a software which is coming from Vienna. It's called context flow. Similarly, even this can identify nodules, and this is a zoomed in version of the many nodules that this software has detected. And in a very beautiful way, it can show us the size of the nodules over time, if it's increasing or decreasing, helping to flag out visually the suspicious nodules. And also, the most important thing in screening is also to look for other findings like coronary calcification, because we know, especially from the studies from the NLST data in America, that patients who have lung cancer, the patients who were coming for lung cancer screening usually died of heart problems and not really because of the cancer, because smokers also have a high risk of cardiovascular disease. What we're doing in Freiburg is that we're trying to develop a pipeline so that we're able to automatically integrate the results of these AI tools into our reporting system through a system called RadGPT, which acquires the fire data from these things and automatically feeds them into my report, so that I have pre-populated reports which I don't have to manually enter every single time. In the last bit, I want to just, this is probably music for the future, but what if we could look into the glass ball and predict if the patient is going to lung cancer even before seeing something suspicious in the CT? And this was a very interesting study which was done at MIT, and they developed an algorithm called Sybil. Sybil looks at the CT scan. It does not require any other data. It does not require clinical data. It does not require any annotations. It runs in the background, and it can predict the risk of lung cancer in the next 6 years for a patient and flag high-risk cases. This is another similar study which was published just last month in Radiology, where they developed an algorithm which identifies patients who are high risk of developing lung cancer over the next 3 years, which also helps us to understand or at least predict lung cancer in this future. What does this mean? Which means for us that we can personalize the screening strategies. We don't have to see patients every year, the candidates of screening every year. For those who have a low risk of cancer, I can ask them to come back in 2 to 3 years. And those who have a high risk of cancer, I can ask them to come back a little early. I can also probably broaden my screening scope beyond smokers and beyond this particular age group in the future to broaden and identify people who might be a risk of cancer who do not have a relevant smoking history, and also reduce the biopsy rate in low-risk cases. This leads us to the future direction where we have AI-enabled personalized lung cancer screening with individualized risk prediction, multi-model integration where we can also integrate clinical data into our models to get a precision oncology and tailor the treatment pathways for patients, and optimize the screening programs by broadening the offer to more patients. And this is the summary of what I already told, that AI can take us from patient positioning, dose optimization, nodule detection, quantification of this, and risk stratification. But we all know that all of this does not come without a price. There are always challenges and limitations of AI in the lung cancer screening. And I just want to end my talk by just briefly mentioning what are the hurdles that we face at present. One is that we have different protocols across the institution which affect the performance, especially in the low dose setup, that the different algorithms, they might not work as stable as they might be cited to work. There is always a high cost of implementation. We have to provide the necessary AI infrastructure to enable this working. We have to pay for the softwares, which we don't know at the moment who is going to pay for it. There's always a black box nature of the algorithms. For example, if you look at the Sybil and the other algorithms that I showed, we don't know how they work. And there's a lack of explainability in these algorithms. There are always regulatory and compliance hurdles. And it's also a challenge to integrate these tools in our daily routine, because if we don't have a good integration, it's only going to add to more burden, only going to add to more time, which is already short and critical for us in the clinical routine. And acceptance is generally a problem, and trust, I think we all have to learn to see how we can grow together and embrace these tools to help us rather than creating more problems for us. And that being said, I'm at the end of my talk and open for questions.
Great. Thank you for the presentation. It was very insightful. Thank you, Karina. So this is a very good walkthrough from the beginning to the end of the cycle that we are managing from the radiology perspective. I really liked also your approach to image quality improvements, like the Clarify algorithm. So why do independent companies create these algorithms? I think this is clearly a task for the manufacturers, that they come out with this software already integrated into their devices. Do you think there's a market for those, that people would buy it as a standalone AI, or where would you see such kind of thing?
So I think it's a two-pronged approach. I think the deep learning reconstruction algorithms, which I was talking before I spoke about the denoising thing, is being tested by many vendors like Siemens, I know of because we work with Siemens, which also is available in their packages. But Clarify, I think, is coming from a much broader perspective for people to have it irrespective of the manufacturer or the CT scan, to put it as a tool on top to improve the image quality. I think it's just not either or, but it's different ways of looking at it depending upon the scanners that you own. Because if you don't have a scanner which provides a good image quality, trying to change it might be much more expensive than trying to invest in something which is just going to denoise your images and equally help you with the image analysis. So I think it's a different way of looking at it. I mean, I might not buy it because I'm satisfied with my image quality, but someone who does not have a budget to change their CT scan machine might actually consider investing in these tools.
Yeah, that's the point. That's the point. And you also showed an algorithm utilizing X-rays of the lung to do some tests for metastasis.
For nodule detection.
Nodules, yeah. I see in our institution the amount of X-rays of the lungs are decreasing. And is there a lot of role for doing CT in the first stage, like screening for infection before they are starting a rheumatologic treatment, for instance, is maybe some low priority for a CT scan? But what indications would you see to directly jump into CT and not perform X-rays any longer?
I think X-rays as a modality is really underutilized. And it's looked at like a stepmother, or stepfather is like more of a German face, I think. But I do think X-ray is right for a lot of things, like for a simple bedside clarification, like a pneumothorax, to rule out a pneumothorax, to rule out for tuberculosis screening. We use it in Germany for its for patients who have heavy migration areas. We have to screen them for tuberculosis. For this, I think it's excellent. To look for tube placements, what we do at bedside, it's excellent, but it has its limitations, because specifically if we are looking at patients who are immune suppressed, and we're trying to see in the face of neutropenia if they're having infiltrates, we have moved away from doing X-rays for these patients in our setup, and we directly ask them to come for CT scans, for example. And also for patients who are looking for fine ILDs and fibrosis, or even atypical infections, especially again in immunocompromised setup. For all of these things, we're always moving towards CT scan, and the low dose CT scans are always they're getting better. The scans, even no matter how low we're going with the dose, it's acceptable to do this as screening. So for these patients, for example, for acute myeloid leukemia patients who are coming in the neutropenia and stuff, we're doing a lot of CT scans, but chest X-ray still remains our bread and butter. We don't see a decreasing trend in chest X-rays. We do it every single day for bedside indications.
Yeah. At the end, clinicians need to pay for the CT scans, and sometimes they are reluctant to do it.
But even, CT scan also takes time, right? We would like to see more CT scans, because I think we are much more confident with CT scans, and our experience with projection radiography is decreasing. And that's where these AI tools come into play. They really help us to get the best out, also while keeping in mind that there can be a lot of false positives, or it just helps us to get more out of the X-ray. And I think AI with chest X-ray is a good combination also in the clinical routine. Yeah,
very, very, very good. Thank you. So I don't see any further questions. Also, we are almost over with the time allotted to your topic. So thank you, Dr. Prina, for being here. And thank you for presenting on this Saturday, and thank you for making it possible. And enjoy your weekend. Thank you very much.
Thank you so much. Have fun. I hope it's an interesting session after this.
It will be. Thank you. So our next guest is Dr. Bastien Guellec. He is a neuroradiologist coming to us today from Lille in France. And he's board certified radiologist in France and has a special interest for large language models and also a lot of knowledge in the use of AI in neuroradiology. He's currently on call in a radiological department and managing some neuroradiological emergencies. But in between, he agreed to speak to us. So, Bastien, I'm very happy that you're here today, and I'm very happy to see your presentation. Thank you.
Thank you very much. Let me share my screen. All right.
All right.
Thank you. So thank you for the invitation, Kay. I was asked to talk about large language models in radiology in 10 minutes, which is a challenge given that the past 2 years have been really booming with research on LLMs in radiology. They've been used to simplify radiology reports, to proofread reports, for translation, for automatic protocoling of exams. And to decide on what subject I wanted to talk, I came back to how I would use them in the past weeks. And I remembered a story. I was on a night shift last week, and I was asked to do a re-evaluation of a patient with an encephalitis. And the germ of the encephalitis was not known at that time, and they just told me to refer to the electronic health record for more information. So I did, and I read some clinical notes, and some were related to the topic, and some, most were unrelated. And by the time I was reading about the patient's ankle sprain 25 years ago, I lost patience. So I did the images, and I looked at them, and then I wrote a report. And this is the interesting part, to look at the images and to think. And I felt like a Dr. House that night, and I said, okay, maybe if the germ is not known, it's autoimmune encephalitis. And I was very happy with myself. I wrote the report, I closed the case, and I went to sleep. And 24 hours later, I was told by a colleague that the internist called, and he told them it was an enterovirus encephalitis patient. And the fact is, they already knew by the time they asked about the examination that it was due to enterovirus. I just could not find the information in the electronic health report. So I did this report, and it was wrong, and I felt very embarrassed, and I felt very bad. And since then, I'm struggling with the fact that the image interpretation was good. It was just an issue with finding the right information in the patient electronic health record. And in fact, finding the two pertinent lines in the record was the difference between Dr. House and Dr. Clown, which I felt at that time. But hopefully it's over in 2025, because ChatGPT is now in our daily lives. We use it daily. Personally, I came across LLMs, large language models, in this article by the team of Keno Bressam in Munich. In the radiology article from 2023, they used ChatGPT to structure radiology reports. It may not seem so impressive, but it completely unlocks the information pipeline of medical texts. And I realized that LLMs are incredible because they are tireless. They can look at dozens, thousands of records and always give the best they can. They are excellent with the text, and text is the most prevalent form of information in medicine. And they are very flexible, meaning that they can adapt to any task. And for those reasons, we started to use them in our department, and more generally in the hospital and in the health data warehouse also. We are focusing on open source solutions which are privacy preserving, meaning that you don't send any information to the Google, Microsoft, OpenAI, etc. We use them for extracting information from brain MRI, but also for other topics, such as detecting allergic event in the patient discharge summary to address correctly the patient to an allergologist afterwards. And so the main goal, I think, would be to use LLMs to chat with the patient record and to find the pertinent information in a matter of seconds in order to give the best answer to the physicians. So you would just chat like in ChatGPT, and this is maybe not too far away. This is just a proof of concept. I just connected a LLM to the health record of a fake patient. I wrote dozens of PDF files about the fake patient history. And maybe it's an oncology patient, and I ask for the baseline performance status of the patient. And in a matter of seconds, the LLM finds the correct information. And it's not as easy as keyword searches because the patient has a long file, and maybe it's he had ECOG performance status before or afterwards. And when I ask for the current performance status, it finds the correct answer. And you may be wondering about correctly about the hallucinations of the large language models. The main point is to try to prevent them. It would be positive hallucinations that are the most frightening, like saying the patient is under such a therapy when it's not the case, and you would have to build barrier preventing that. So this is just a prototype, but it's not too far away. In fact, the Stanford team already launched the Chat EHR robot, which is their solution. It's already plugged in the system of physicians there. And I think that it could really make an impact in the clinical workflow of radiologists, because we are so used to discuss with information that it would really gain some time. But really, it's a paradigm shift, moving away from images, moving away from expertise-based tasks. For example, detecting hemorrhage in a brain CT scan, to more information-based tasks that may not seem maybe so impressive, that are maybe less sexy, but they are such burdensome tasks, and they are so critical for our response, that they allow us to focus on really the bread and butter of our job, which is the meat of our job, which is interpreting images. And we love to do that, and allowing us to do it in the best condition would be interesting. I cannot do a presentation on ChatGPT and radiology without saying a word on image interpretation. And my main point is that you should not use ChatGPT to interpret images. We did a short article on that this year. In fact, it cannot even recognize the organ you're sending. For example, this is a coronal slice of a brain MRI. And the robot said it showed cystic lesions in the sacroiliac joints, which is completely false, of course. But if you still want to use it in radiology, I strongly advise you to describe the images to them. It's a recent paper on medRxiv we did with Soo-Wan Kim, who is in Munich. He showed that the better the image description is given to the model, the better is the model at giving the right information. And you can see maybe there's a paradox, because if you're already good enough to give an excellent description of the images, maybe you don't need the input from the LLM. And the people that would need the most the suggestion from the LLM, they are maybe unable to give a correct image interpretation to the model. So it's not clear how it would fit in the imaging description pipeline at the moment. So please, if you use ChatGPT in radiology, don't send images. Maybe give them some burdensome tasks that you don't want to do. And I think that it's here the most promising benefit for LLMs. They are so good at communication. They are tireless. They can work with text so brilliantly, and they can ingest new knowledge that is appropriate to your clinical setting. And to finish, I just want to say a word on a project we have with Keno Bressem. We are passionate about the clinical applications of LLMs, and clinical application meaning it can work in any setting, in any language, and most of the work for now has been done on English texts. And we want to test it, to stress test it on multiple languages, and we build a database that's called the Parrot, and it's based of thousands of radiology reports in many languages. and we are actually testing applications of LLMs on them. So if you're interested in LLMs and multilingual applications, please reach out either to me or to Keno. So this is a very brief talk about LLMs in radiology. I could talk about it for many dozens of minutes, but please reach out if you want to discuss it some more. And thank you to my two PIs who are Gregory Kuchansky and Aguilas Amron in our department. Thank you.
Thank you, Bastien, for presenting. It was very insightful to learn about LLMs. So the usage of this technology is quite diverse, and I very much like the idea to ask the chat about the patient, about this specific patient, because this would lower the burden of also the referring doctors, because they would not need to fill in a request form with information. They just mention the patient, and the radiologist pulls out different information than the gastroenterologist doing the colonoscopy, than the surgeons or the anesthesiologist. So this is really something I very much like, and I think a lot of doctors will benefit from it. So the participants, if there are questions, please use the comments box so we can keep the discussion going. Meanwhile, I would be interested, of course, this all needs to be done in-house, within the walls of the hospital. So there are like open source large language processors or models. Which one would you recommend? Let's say you are in the IT department of a hospital. You want to provide this technology to the 5,000 doctors. Where would you start?
I would. This is a very interesting question. I would start by benchmarking the models on the data from the hospital. We have made lots of tests, and the models, they are behaving very strangely depending on the language, depending on the text, depending also on the prompt that you use. It's very sensitive about different kind of settings. So I would build a pipeline that allows for iterative testing of available models. There's no single recipe on how to do the best data extraction.
Okay, so we might get back to him. Somehow the connection was just interrupted, but he's already
sorry.
back.
So sorry, it's the
You're
internet
back.
connection.
Yeah, no
so
worries.
the second thing is that there are new models that are arriving basically daily, and you would need to adapt to what's new on the market. And the models that were here maybe 2 years ago are completely obsolete now, and there's no definitive truth about that. Having that said, I think there's kind of a plateau of the performance of the models now, especially open source ones. So you could start using a Llama 3 model, which is a good model. The Qwen 3 model is also very good, and because I'm French, I will say the Mistral model, which is also in some aspects open source, is interesting, but really you have to test it in practice.
Because I think one of the challenge is to separate the different patient records. So let's say you have a hospital with 1,000 beds. You're overlooking like 15, 20,000 patients in the last 10 decades. And then you want to have an information about the one patient you are looking at the screen. And then it's important, I think, that the answer comes strictly from that patient record and is not like influenced by patients of the same ward, of the same disease. That's very important if you really want to use it as a clinical tool and not just as a playground for research.
Yeah, completely. I think the model should be linked only to the file of the patient, and through retrieval augmented generation, RAG, you can create a library of all the data about the patient, only the patient, and give access to this information only to the model and not to all the information available. I think it would not make any sense. You need to be very patient specific. You are completely right.
Okay, great. I don't see any specific questions. There's a lot of good comments coming in. And thank you, Bastien, for taking the time. It was very insightful. I hope we can continue our work together in the future and enjoy your day in the hospital. Thank you. So my next speaker is Pascal Balzer. Pascal Balzer is, as I think, of German origin. He started his career in Jena, which is in Thuringia, and he developed himself to an expert of breast imaging and later also prostate imaging. He worked together with Professor Kaiser, who was a pioneer in introducing MR mammography into the routine, and I think you bring a lot of heritage already in the terms of radiology and breast imaging, prostate imaging, and I'm curious on how you develop this further in Vienna, where you are currently appointed as a professor. So Pascal, please bring your presentation to us. I'm really curious about it.
Thank you very much, Kai, for this kind introduction and the invitation. It's a pleasure to be here today. I will just go deep into practice. As I said, breast and prostate imaging, a little bit more specific. I very much enjoyed the previous talks, which covered topics which I did not cover. So that actually is pretty great. I have no conflicts of interest regarding this talk. Probably as I'm an editor, I'm always a little bit critical on research assessment, and that will be part of it, of course. So first of all, promise and potential of AI in these fields. And the main question that arrives is, why should we do AI in radiology? I mean, it has practical applications. I think the last speaker very clearly pointed out that we really probably need AI. But one of the things which I noted when you start like working in the 90s and you're now in the 2020s, then you see that we really have a rising workload, a shortage of radiologists. Is that really new? Well, not so much. There is like UK workforce census, whatever. But if you just look back into the literature, 50 years ago, we already read about shortage of radiologists, right? So, but if you look into really the literature, at least it is trending. We have a steady increase, actually an exponential increase of the wording shortage of radiologists. And of course, there's a huge potential of workflow improvements, which you've seen also in the previous talks, both for screening and the use of LLMs. Now, we have, however, also the risk of over-enthusiasm, because what's a real-life impact and who takes the responsibility for missed findings? Let me just go deep into breast practice. Breast practice screening is not like beginning, but we have breast cancer screening since the 70s and worldwide, and there AI is rapidly evolving. And on a rather recent meta-analysis, where I had the pleasure of doing all the statistics and stuff, we found out that standalone AI for screening digital mammography performed as well as, or even better than radiologists. One of the things, and this always when you publish and you have a consortium of people, some messages should not like go on the front page or the abstract. And one of those things inside that article, you can read it up, but it's not like advertised, is that studies where the vendors were somehow involved in the study design showed significant worse results of radiologists. So radiologists somehow perform worse, AI always performed better. And as there's a lot of vendors was involved, probably the impact of AI was a bit overestimated. There's, however, two landmark trials. I will just quickly guide you through them in breast cancer screening. One was the Maasai trial. A little bit of cultural appropriation here, but we see even in the year 2025, it's something to be improved. Now, they used one specific AI tool. That's the one point I will make repeatedly over this talk. AI is not AI like a general thing or something, but usually refer to specific software. It was used for either triage or double reading, right? So we had a workflow where you have rather normal reading, and then you have the single reading plus AI if the risk score is low or intermediate. If the risk score is very high, you have a double reading plus AI. And what they found out is that there's a slight improvement in cancer detection rates. Usually in breast cancer screening, they are between 4 and 7 per thousand, so no big change. But the workload was decreased by 44%. And if you go into the details, actually, the pure numbers speak another language, right? We have 338 versus 262 cancers in screening. We have a lot of patients which have nothing. So increasing the cancer detection rate per population may mean quite a lot. In this case, it was quite a lot. And if you look at the false positives, the rate, but also the numbers were more or less the same. So there is clearly an improvement here. And that was independent of the age group, of course. And those age groups where radiologists have a challenge, there, interestingly, the impact was probably a bit higher, but the impact was measurable over all age groups. We currently do not have any outcome data regarding interval cancers, which would mean that the AI somehow improves clinically significant cancers, right? We don't have that right now. We're talking purely about the radiological workflow. Now, there is other landmark trials. The second is the Screen Trust, and believe me, it's the last one I will bore you with, but the results are interesting. What they compared is like classical double reading, single reading with AI, or double reading with AI. And what is interesting to me is look at the green bar, lowest abnormal interpretation rate, lowest recall rate, lowest biopsy rate, but similar cancer detection rate. So the results are a little bit similar than the other trial. And yes, you can see, okay, if you put the humans into the loop, then you improve your cancer detection rates as compared, of course, to the standard of care, while AI has the same cancer detection rates. False positives, however, are slightly increased, but they are decreased if you use AI only. Interesting results. So to summarize the evidence regarding breast cancer screening, AI is non-inferior, regularly even superior to humans. Recall and false positives are stable or even reduced. The workload can be reduced by 30 to 40%, just in numbers. It's not meant in hours. It's one of the points of criticism, but it's probably too much now here. The evidence is still short-term. We don't know about interval cancers, outcomes, overdiagnosis, but it's pretty clear it makes use of the same method. It will be more or less the same. The provoking thought, however, that comes up when reading those studies is, should we probably use only AI? Because there are several implementation models. First, AI triage. AI filters just out those examinations which are negative, right? Probably the workflow reduction is not as high because in a mammography screening, it's very quickly done also by a human. It's some sort of rest. Then with the single reader plus AI, this is, I think, what will definitely come to replace the second reader with its very little impact. AI as an additional reader as a safety net, also interesting approach, but an add-on. And if there's no real outcomes for the patients improved, probably not something which is going to come. And then the full AI read, which is exploratory only, but exploratory only because we're talking about like in an experimental political difficult setting here, right? If we look at the USA, and the USA are probably the industrialized Western country, where you see, depending on where you live, you have more than 1 hour to go to mammography practice because the density of doctors, physicians, machines is not as high. And there, of course, AI as an interpreter could alleviate those things, as of course teleradiology could also do. Also, what we know is that in screening, the performance of inexperienced or even non-screeners is much worse. If I guide you to the location sensitivity of non-screeners in mammography screening, the sensitivity is less than 40% to correctly identify an abnormal area. And that, of course, could be fully compensated for by an AI system. Now, there's, of course, negative aspects to it, the dark side of the moon. First of all, the accuracy in articles you read and the unconscious bias there. What I also said about the vendor bias. In this case, it's a prostate study. It's very similar in the workflow. It's a representative study, very well done, published in European Radiology. They used a huge database. They trained and validated their setting. They tested it on an independent, publicly available data set. So everything done according to the books. Well, now comes exactly what was found in the meta-analysis for breast imaging. The comparison, the radiologists who performed worse than the AI tool were actually inexperienced. You don't read that in the abstract, you read that in the paper. We said just board-certified radiologists with some years of experience, less than 5, mind you, in general radiology. Those are not prostate radiologists, right? So here is the example. I always like to go into the images. There's true positive cases, right? So I think even without having attended a course on prostate imaging, you can say, oh, wow, there's a cancer. Oh, wow, there's a cancer. Typical presentation, Pirates 5. Actually, at a glance, I don't even need to zoom in, right? Oh, the AI detects the cancer, but now pace yourself. The radiologists didn't. And the authors put it very transparently in their article. But usually it's not what you read. You only read the final results. And here, definitely an absolute beginner false positive. No one who ever did just 1 week of prostate imaging could do that mistake. Oh, the radiologist did something false positive. And here, evident inflammation, really, you can't mistake this showcase, textbook case, AI and radiologists with false positive. These are the examples. Examples are usually chosen, was a recent article in the EJR, by the authors to make their point. So this is the best the authors likely could come up, improving like how it works. So you see, The whole system may have been done right, but the interpretation of the findings is just plain wrong because the comparator, the humans, were just evidently not at all experienced in the field. That brings us to another issue, that is automation bias. There's a nice study from Cologne Group done in radiology a couple of years ago. They show that if you do a fake AI system, readers will just follow it. They'll just say, oh, okay, there's the cancer. Because it's more simple, you're also the liability and so is simple. You could just go on it like the user auditing, that you really make the user responsible. You give them always a feedback what they found themselves. Also, like, use the AI only as a safety net, and of course an AI system that tells you, okay, I'm absolutely sure, I'm not so sure, even though I give a diagnosis, I'm not sure at all. I think that's one way to go to alleviate this aspect. I will also not too much go into these implementation challenges. Just mind you, a CE labeling is just a technical validation. FDA clearance is rather simple to achieve even. There's a lot of bureaucracy, but it's not something that needs to be repeated. Another aspect I will just repeat, I think, one slide later. We have in Europe the EU Act, where AI tools so for medical imaging are considered high risk, so 3 out of 4 levels. There's a lot of regulations now coming, which are all interesting to discuss. Probably you have time in the questions. And one of the things is always to discuss the liability, who is accountable if AI misses a cancer. Currently, that is, of course, the user, the radiologist. And then there is lots of issues in workflow implementation and integration. One of the things that I usually need to smile when people predict that in 5 years, humanity is not there anymore, because I think that even in Austria or Germany, there's lots of areas where we actually don't have the infrastructure to make use of AI tools. Never forget, AI is a pragmatist. There's a lot of talk about bias, particularly from the US, which is much more interesting, like I think about ethical bias whatsoever. But one of the things, of course, is that AI is always a statistical solution to the majority of cases. So in some cases, and sometimes you can't even see it, and sometimes really bitter, the AI tool will actually ignore you. And if you're in subpopulation, you're lost. And one very good example here is actually Officer Ash, who was an android, which the people didn't know, on the interstellar towering vessel Nostromo from the movie Alien. And he, for the greater goal, securing the alien, actually got rid of the whole crew of the Nostromo. And yes, when you look at it from the personal point, that's horrible. But in the general, you can understand it. So AI is a pragmatist, which is a bit shocking if you think about it, because it's not a human who is accountable. But in the end, is much more likely, of course, that AI will reduce patient harm and improve our practice rather than being this dangerous as depicted in the movies. I will also probably, for time reasons, not go too much into trustworthy AI. Trustworthy AI needs to be accurate. I give you an estimate on how accurate it is. It must ensure your privacy. It must be reliable. So if you repeat it, it shouldn't do like something false positive, false negative, like in this generative AI exam. And of course, it should be transparent, at least to a level regarding its own accuracy. Now, finally, regarding clinical implementation on partnership, one of the things which I already hinted at is the problematic use of the term AI. AI is usually software tools based on some AI or machine learning technology. So of course, we have a device or domain shift, which is conceivable, even though at least for breast imaging, this has been studied. There's, for instance, no real bias if you train your data on a logic and use it on Siemens or something. One of the more interesting things is here regarding the implementation of a software upgrade was that even AI software versions may differ. And there we are again at the FDA clearance. And so currently there's no real post-market surveillance of this. Also, of course, any AI tool must be calibrated to the site. Just mind you about the technical aspects or prevalence of disease at your constant site. So you need constant auditing here. But what is the perspective of the affected patients? And here is a perspective of women. And women actually care only about one thing, diagnostic accuracy. They don't care so much whether it's an AI or whoever is achieving that. That's also one very important point to consider, even though for liability reasons, probably we need some patient-informed consent regarding AI tools. Finally, let me guide out like the workflow changes which have been examined for prostate AI. In prostate AI, of course, it's very similar for each complex workflow. You have an image preparation, then you got a reading, you have various steps in your structured reading approach, and then you review it usually with a senior physician. If you do it in many private practices, this is of course not done. How can you use now AI? You can use AI by uploading it to the system, doing your manual reading in the background. The AI processes the thing, and then it's just done for proofreading as a second opinion. Or you consider the loop that you transfer, then you do let the AI tool do everything, then you check what it has done and review it. And this study focused on the workflow improvements. And the conclusion was, as you see, there was a lower standardization and no effects over time on radiologists' workload or stress. So expectations for AI decreasing the workload of radiologists were not confirmed in our real-world study. And also what I said for the breast, which is just numbers, which has not been measured like in hours and stress and so on. What I found more concerning here in this paper is, however, the numbers of interruption per hour. There seemingly was a general issue in the workflow of that department. Now let me come to an end. AI is definitely ready to assist radiologists, not only prostate and breast imaging, but also you've seen the large language model or lung screening assessment. It may also serve or open up underserved regions, for instance, like there in breast cancer, where you can really alleviate for the training and the lack of trained radiologists. AI usually refers to a variety of software applications and even versions, and that needs, of course, adjustment and constant monitoring. We need a use case specific assessment of the safety, efficacy, and workload reduction. In each and specific scenario, we need to track, does AI really help here or not? Is it also cost effective? In real practice, you always need to audit your data. I strongly recommend to any radiologist, any clinician to audit their practice. And of course, we need legal clarity. There's some very interesting ideas that are mitigating liability strategies up to using AI as an autonomous legal person. Very interesting to discuss. So all processes, I think, here are where physicians and also the patients should get involved in order to speak about it, because otherwise all the policies are done by people who are not practically involved all the time. Thank you very much for your attention.
Great. Thank you, Pascal, for delivering this, like a really cool lecture, I have to say. I have heard a lot about of trustworthy AI, and you mentioned it. Can you elaborate on how to produce trustworthy AI compared to a standard AI? What different steps do you have to do in order to have the label trustworthy? I also guess there's no real like definition on when you can say it's trustworthy.
Yeah, that's a very good point, Kai. So I also, it's just my personal opinion. What is an AI which is trustworthy to me? Most of those tools which are used to train AI are black box tools, and we can't really change that. However, each and every AI, even this most simple machine learning model, provides you with a score with a probability, which then has to be calibrated to the real test scenario, right? So yes, an AI tool can, just following also RC statistics, can tell you, okay, here I'm absolutely safe. Like in this pre-filtering, it knows that in this case, the probability of a missed finding is 0, so it can clearly say there is no finding. And just that if the AI just doesn't do the 0-1, the recall or no recall action, but says, okay, this is to me a recall, but I'm not sure, but I'm very sure. That gives you already, it's to me already very trustworthy. And that if that works in practice, if I audit it and see, okay, in the unsure cases, it had like a 50% accuracy. In the absolute sure case, it had like a 90% accuracy. And it was said from the beginning, if I know this as a user, then I think it's already pretty trustworthy. All the other aspects, of course, like I think they go without saying, like privacy of data, if you have like some cloud solution, all also more legal aspects. I think that goes without saying. But to me as a user and also probably as a patient receiving a diagnosis, I would really like to know how accurate the result in my specific situation is. And I think most machine learning models would allow you to provide that estimate.
Yeah, and how would you audit an algorithm? Let's say you are in the position to buy and select 1 out of 3. Would you then provide like 100 cases that you label yourself and provide them, or would you provide 100 cases completely unlabeled? Or how is the process of auditing software before you buy? How do you have insights maybe about this?
It's a very good point. I think there's many colleagues working on those aspects. So as I said, I strongly believe, and that was something I took from Dr. Kaiser. Dr. Kaiser was practically the inventor of breast MRI. What he did was every 2 years, he reviewed all his cases pretty crazy. Like during night shifts, you review them just to check. When I said it's negative, what is there? Because you can report, for instance, I reported in my residency, I don't know, I think I counted it, 37,000 x-rays of the chest, which is crazy. Am I a good chest x-ray reader? Not at all, because actually the only reference was there, like the consultant saying, well, that's a pneumonia, or that's not, that's actually just guesswork, right? So you, of course, need that audit. To do this practical in practice, so I think in each field you are, if you do prostate MRI, you should somehow audit your cases, probably by just having a conference, building up a database where you have cases, where you have the reference standard, ever was read. And if you have some of those databases, and probably in a comparable setting, it would be great to have like some public database where you just test that data set, that you don't need to rely on the pure information by the vendor, but you can, based on public data, on your own reading, just check how good it is.
Okay, and then the final question: you're a long-time user of breast MRI scans and mammograms, and before 2015 we didn't have AI, but we had other solutions to have computer help to detect cancer. They were more based on computer vision and calculations and physical appearances of the screen. How's your experience transitioning from the early software versions like the R2 Mammo reader, how was it called, and the new software? Is it really like a real game changer? Is it similar, or is it a different aspect that's now emphasized with these new software types?
Yeah, well, there's of course lots of marketing behind it, right? So it's all computer-aided diagnosis, and just naming it AI doesn't really change the world. However, of course, like the computational power behind it is just higher, and they're just like refined, like second generation CAD tools. So of course they're better. They're particularly better that they don't do that many false positives, and they give you actually most of those softwares nowadays really give you already an estimate of what the risk score is. So they don't only have areas, but they provide you with a risk score. So yes, there has been an improvement. I think most people were really, really not very happy with those old tools. They were marketed as game changer. They were not. The new tools are again marketed as a game changer, but they are practically useful. The only thing is, for instance, which I need to point out, for instance, in Austria, practice is actually the screening practice is like in curative mammography. So the patient comes to me as a screening doctor, and if there's dense breast tissue, I do the ultrasound. So actually, in an Austrian workflow, probably it makes sense to use AI as a second reader, but the use case is not as high as it would be in Germany, where we have real batch screening and you have to read 200 exams per hour. That's not the case in our country, and that was one of the cases which I meant. Like the use case specific workflow. Also in prostate MRI, I, for instance, as a large scale user, I sometimes report 20 or 30 prostate MRI in an hour. Then of course, like it's a high throughput level. There probably I could make use of AI software, which would really help me. How is it just to calculate the volume or something? But if I only have 5 prostate MRIs per week, for what do I need an AI solution, right?
Thank you, Pascal, for your insights. I also loved your notion of expert radiologists who are actually better than AI, but they need to be on the forefront on developing. So if general radiologists are developing or are helping to develop the algorithms or are consultant to the companies who are selling it, then AI might have not the good results. Usually the experts like you for prostate, they would need to go into that process. On the other hand, they have a lot of workload, as you said, what you read in 1 hour, and they usually don't have the time to consult with these companies on how to do it. So this is something that's maybe for our next discussion. Yeah. So thank you for your time. Warm greetings to Austria. Enjoy the autumn sun. You see a lot of good praise comes in from all over the world. Here, some friend of mine from Turkey switching on, and thank you, Pascal, for being here. And this brings us to our final speaker today, which comes to us from Denmark, Michael Bøsen. Michael Bøsen is a professor of radiology, and he is working in a very exclusive research setting, working with osteoarthritis research, arthritis research, and has recently also stepped into the field of AI testing and AI's auditing in a public-private partnership. I'm sure he will present the data on this system now and how the people in Denmark have approached it. Michael, I'm really happy to have you here on screen. I'm really happy you have some really good X-rays in your background. I already had here my X-ray T-shirt today with Konrad Röntgen. So we are celebrating together here today, and I'm very curious to see your lecture today. Bring it.
Thank you, Kai, and thank you for the invitation. And I will try to follow up on the great talks that we've just heard. So my name is Michael Boes, Professor of Radiology and Head of Research at two university hospitals in Copenhagen, Denmark, and then I have co-founded the Radiological AI Test Center in 2021 that is testing and validating and implementing AI solutions where we see feasible. So my talk today is basically on this is my disclosures and let's see, I can't here. So the challenge is that, as we heard before, and I'll try to convert it into why we need AI also in musculoskeletal radiology. We are drowning in data, both now and especially also in the future, because we are having all these new technology advances and solutions. So we're going from multiparametric or single point of care imaging to multiparametric imaging. And we have, since the millennium changed, added 10% extra imaging on the same diagnosis every year. So we're going from anatomy to ultrastructure to inflammation quantification and to metabolism, and combining that. The clinical trials are fueling that. But when the clinical trials are over, then there are companion diagnostics that we need to take into the clinical world. So we are also pressured from the clinical trials in order to add more and more images to the same question. We heard before that radiology is becoming the bottleneck because we are educating linearly and we have an exponential increase not only in numbers of examinations, but also in the size of the examination. So the data doubles every year in radiology. So we are becoming this bottleneck, and especially in musculoskeletal imaging, we also have to remember that defined pathology is heavily present in patients without pain or symptoms. So when we do imaging, we detect a lot of findings that not necessarily have to do with anything that the patient comes for. So can we then solve that, let's say, drowning potential that we are digging ourselves into with increasing workloads and also burnouts with the help of AI? That's the question. An available AI solution in musculoskeletal imaging is not as, let's say, many as in other indications, but we have seen that AI have been introduced in imaging for the last 20 years because we are the most digitalized specialty, and we have been paperless since the millennium change. So if you look at a patient journey, we can digitalize and use, let's say, advanced technologies and data analytics as well as AI in the whole patient journey. And that has become, let's say, that's been hidden in the machines for 20 years, where we did machine learning and increasing noise reduction. But similar with the ChatGPT that came out in the 2023, then in the 2020s, we began to see the increase of decision support, meaning that image analysis support tools. And since then, radiology has been the major specialty that have these tools, basically because we have the same data format. Without the same data format, forget of scaling AI. So that's the hurdle of all other specialties in medicine, in my opinion. So we have, let's say, 90% of the market still. And there are more than 1,000 FDA and CE approved AI algorithms today, where more than 600 are within radiology, actually now 750. If you then look at the webpage that also was mentioned before, it's Health AI Register. It's very, very good oversight of FDA and CE approved algorithms, especially from the CE market approach. And you can see here that today there's 280 approved algorithms. There was 100 in 2022. So we are also exponentially increasing there. And if you click at MSK, we have 44 approved MSK solutions, 23 for radiographs, 6 for MRI, 14 for CT, and 1 for PET-CT. So digging into that, all algorithms, has also been mentioned also in the previous talk, they have to go to some rigorous regulations and approvals. It's the CE mark. It's a technical validation. It says nothing about clinical, let's say, usefulness. So they perform very good. Otherwise, they will not be approved. When it comes out to reality, up to 90% of people, they have seen that the proof of concept that they saw or the white paper that was behind the approval, they perform differently when they implement their own solutions. There are a lot of reasons for that, and mainly because we have different data, different techniques, different scanners, different software versions, and a lot of other things that are different. So you cannot just trust in the CE mark to say that you have whatever is promised in that. We also have to take care of all the challenges, because clinical data is a mess. It's full of holes. It's very noisy, whereas the data behind those solutions are usually cleaned up in a similar laboratory setting, so you know what is what, and then the performance is ideal. There's a lot of pitfalls with biases, and I have not time to go into it, but every step of the way, generating data introduce some biases. We as human introduces biases every day. I read, as Pascal was mentioned, I see images that I did 2 years ago, and I said, whoever wrote that diagnosis, because it's wrong, and it was myself. So we continue to learn as humans and also make mistakes. 1/3 of all the 40 million mistakes in Europe in healthcare is errors in the radiology report. So I have to remember that. Thus, you cannot use the radiology report as training for the AI solutions unless you clean it up so you know what it represents. So some of the examples in MSK radiology is let's say sequence-based. So we have sequences now that can speed up examinations. Now we can do a 5-minute knee scan that usually took 20 minutes when I started, maybe 30 minutes, with the same quality, because you scan with low resolution and AI algorithm converts the data into, let's say, some crispy, nice images. And that also impacts the performance of AI if it's only trained on retrospective data, because this is newer techniques that are coming and implementing in the scanners. We also see CT scanners where we now can simulate or MRI scans where you can simulate a CT scan. It's called zero echo time imaging, and there's various solutions out there, also commercials that you can implement. Otherwise, you can do it yourself. We see now, let's say, because of the discussion about contrast with MRIs, now we are having AI to see virtual non-contrast images. It's called FLAIR, double FLAIR, accelerated FLAIR, and they use some AI reconstruction algorithms to actually enhance synovium and depress fluid. So you can, let's say, basically see the same, at least the volume of it. It's not as good as the contrast, but it's getting there. We also see solutions where you can grade, for instance, knee radiographs. You can standardize that, and we've shown that in our institution also with Kai, with the pan-European free center approach with different imaging techniques, different acquisition in the clinics, and apply this AI tool to grade the knee osteoarthritis. And we had a very high performance across, let's say, readers, especially the non-experts were improved in quality to the level of the experts, which were 3 professors in MSK radiology. So that's really good. And then you can uniform the grading now, despite of what you did. So this tool basically is more transferable, regardless of how you acquire the images, AP, PA, long legs, or standing in a device or whatever. So that's promising. Another thing is that we have implemented that because we wanted to save unnecessary MRIs. 75% did an MRI when they had osteoarthritis of the knee. The recommendation is that you shouldn't have that. So we implemented it now in the acquisition room of the X-ray. So the technology is now, with the help of the AI, actually deliver the results to the patient, sent them home if they had OA on the knee X-ray. If they didn't, they had a same-day MRI examination of the knee. And then we saved 30% unnecessary MRI, but every patient was seen on the same day. Usually it was 2 separate days for the X-ray and the MRI with a hiatus of 4 weeks. But it took 20% of 19 persons' time to, let's say, implement this new workflow. So don't underestimate the implementation issues. The other thing that we looked at is fracture detection. This is a very promising tool. Several, let's say, good companies deliver this. And this is one of them where we actually saw that luxation and fusion, it performs very poorly in our data sets, which was consecutive data with all the wrongs and the erroneous or the poor projections and the noisy ones. It was implemented because that's real life settings that you need to test in, where it was very good at long bones, but very poor where humans also had problems like, say, small bones in the hand and the wrist, and also in the tarsal bones. And in children, there was also, we couldn't use it for fusion, and there was probably also poor performance there because of the growth plates and all of that. So we are in the decision, should we use it, should we not? It has a sensitivity of 90 and a specificity of 90, which is commonly across the line. But it can, let's say, help us with obvious cases. It can also show something in the middle image where you actually see that there's an infusion, but they missed the fracture in the radial head. There's, let's say, a dislocation here, but it missed the fracture there. But again, then you can also use it for, let's say, confirming or seeing difficult to see cases, at least for non-trained eyes, where there's fracture in 3 digits here, also in the foot, and here in the shoulder case that was really missed by one of our experts, where you can see the CT scan that was a bicyclic accident. So it has really high potential of also seeing something that humans have very difficult seeing, but you need to test it on your local data, as previously mentioned. There are several good tools to actually do reproducible and accurate measures, orthopedic measures. So the question is now in the field, should we do it as humans because we are really poor at this? So why not make the machines do it? We have for a long time, more than 20 in our institution, performed, let's say, age grading on X-rays with the help of an AI tool. It was a vision tool first, now it's an AI tool. And it performs very good, and we do not even pay for it. It's the children's department that pays for it. Also coming for MRI of the spine, we see that there's a potential. We can also quantify now diffusion data, color-coded. We've been able to do that with machine learning for a very long time. It was part of my professorships doing that. Now we see that not only even can you do a 5-minute scan, you can also segment the bone and do volume of that and the cartilage. Is that interesting in clinical setting? Not yet, but it's really interesting in a clinical trial setting, where these are the endpoint for structure. You can detect lesions in the knee, segment muscles as well, and segment CT scans, where you can measure muscle volume, sarcopenia. You can do BMD on CT scans. Every CT scanners today are more and more becoming dual energy, at least, and dual energy can actually measure BMD much better than DEXA. So we have really the potential of doing biomarkers with the help of AI here. There are tools now also that can detect bone and also help you to detect tumors in the bone, fractures in the spine, fold out images, so you easily can see fractures, for instance, in the rib and in the vertebral column. So all of that is very promising, and it has a really high performance, but very slow adaptation. Ultrasound at the final slide here is also coming, so you can quantify effusions, synovitis. You can even scan now with a robot, so without human in the loop, you can do a full hand scan for rheumatoid arthritis, let's say, diagnosis as well as monitoring of disease. So all of this is coming and being adapted as we speak. So there's no doubt that AI is here to stay, and we need to jump on that wagon. Otherwise, we will be left on the train station, where the ones that use the tools and get acquainted with them, even though they might not see the great potential right now, especially for this as experts, they need to adapt to it. And many places are beginning to do that, and every year it's picking up as we speak. So finally, as a summary here, the AI method has been utilized for detection, scoring, grading of fractures, osteoarthritis, on conventional radiographs, CT scans, MRI scans, can segment bone and cartilage, quantify inflammation, and monitor treatment responses, and help us with that. But we don't know very much about how it compare with human readers, the external validity, which is very important, tested on your own data, and test very many different algorithms before you choose the one. Correlations with AI during measures and other validated imaging-based measures between the clinical outcomes and the predictive value, as well as the implementation value in a clinical setting. Those are still unknowns, but we cannot answer that questions before we begin to use it. And thank you for your attention. I'm happy now to take any questions.
Thank you, Michael. Very nice overview and very good, also usable systems you presented. And you stressed the necessity to test the algorithms on your own data. We also had it with the other experts, so that is key. So that means if you are having a fracture algorithm that you buy, and this one was maybe developed from a French company, and you are now implementing it in the Nordics, you would re-evaluate it with local data, because the fracture patterns are different between the different countries, or so people are playing paddle in the Nordics and tennis in France, or can you explain more why this would be needed?
Yeah, for the fracture detection, we're implementing and learning, and when we test the various algorithms, they actually perform on a let's say overarching level similar. There are 2-3% difference in sensitivity and specificity, but that is not really the case here. So if you dig into the lesion specifics areas, so the bone specific areas, there are differences. So some perform very good on the hand, or better on the hands, others on the hip, and others on the foot again. So you can really not say from an overarching point of view, which is presented as accuracy, sensitivity, and specificity on the whole data sets, whether it would work really well on, let's say, your hip. That's what you need to say. And then you have to question, what are you going to use it for? Who will use it? Right now, as also was alluded in the previous talk, for the expert, it doesn't really make sense. It takes more time because it tends to be a little bit, let's say, less in sensitivity than the expert, and also a little bit less in specificity, meaning you make more false positives. So you spend more time using it. But for the untrained, you can really take a big leap into becoming more or less an expert. Whether it's grading osteoarthritis or detection of fractures, that really is helpful. But that's not necessarily in the Department of Radiology, it's in the emergency department. So for the emergency physicians, where you exchange the personnel, it's the young doctors coming in, they have 3 months there. So you have 100 of those in our institution every year that come to new and then leave again after 3 months or 6 months or something like that. So here it really makes sense, but then who should pay for it? What's the performance? What are the pitfalls? That's the question that we need to help with, because it also comes with liability, and it's the users that are liable here, and we need to prevent that. So that's why we need to build a system to be able to test on your local data before we purchase its procurement, so you can test various algorithms. Then you have to run it, and then you have to monitor it while you use it. It's called drift. That the algorithm is static, it's locked in the equation, but the data changes over time. So you might drift in performance over time. And if you can't monitor that, then it's just guesswork. And then you also have to take it out, as according to the new AI Act. And when you take it out, because it has drifted, then you need to retrain it on your local data. And retraining means that you change the sensitivity and specificity sweet spot. That's very technical, but it's something that we need to have in order to scale these algorithms in a larger sense. We can handhold it, simple algorithm, it can be done by just doing that, but it's coming now, and we have more than 600 let's say in radiology, and 280 in CMARC in radiology in Europe. So there's a lot of these, and they're coming fast. So we need to be prepared to be able to address them, to use them. But there are use cases out there, and as every hospital is also different in organization and in who do what. Some do readers with let's say text that reads images. Others do not allow that. Then you have nurses that handle fractures in the emergency room. Others do not. So it's really much depending on who is the person that uses it, for what it's used, and we still do not know that. You need to trial and error that in your local institution. That's why it's so difficult to scale, not to validate. Accuracy, specificity, all of that, that's the easy part. The implementation
Very valid
part
point.
is difficult.
Very valid point. So you mentioned the notion of who uses the algorithm. So obviously radiologists, one might think, are the first, but you already pointed out, no, maybe the doctors in the emergency department, maybe the reporting radiographers or the emergency nurses even. So that also varies from country to country. I know that Denmark is very has a very huge gap in radiologists needed. So there are a lot of reporting radiographers or trained nurses. We don't have that here in Germany. Maybe it's coming because, of course, workload is very huge. And you also mentioned that training is important, and that sometimes it takes longer for the experts to deal with all these markings and to go through the validation of this stuff. So thank you for these insights, Michael. I think you showed that there's very good solutions out there. Maybe you can tell me a little bit about your testing center that you were running the last 5 years. What exactly did you do? You had hardware and also software running there.
No, we as we helped a Danish company called Radiologics that now have a solution for fractures, and also have a solution on the market at that time for knee osteoarthritis detection. We could see it coming. So, and we could see the problems in 2020, that how do we deal with this? How do we validate it? How do we implement it? How do we use it? Where should we do it? And as these first generation tools that are most of them out there, it's called point of care tools or narrow task AI. It solves a task. So how do you solve that task when the task is differently handled and the action on that task is different in different organizations? That was the question there, and that's why we made a virtual organization between 4 hospitals in the capital region out of the 7 that we are, to actually go together and try to make something out of this, to take the algorithms out there on lung x-ray, on brain, on whatever, and then clean our data, consecutive data, also the noisy ones and the wrong projection, all that, to test and simulate a clinical setting. But that took, let's say, organization, and we have had now 12 PhDs and 2 postdocs, and we were 19 people running this on a grant that we got, a large grant, and that's running out now. But we managed to change the law, the health laws, to be able to secondary use of data and continue use data progressively when we implement it, not only retrospectively in research, but also progressively, which is needed for monitoring. So all of that was not done, and nobody knew how to do it. And so we have done that because we saw the problem and tried to solve it. We didn't have the infrastructure either to monitor, to take it algorithms in, to test it on the local data, and then implement and monitor and take out when it's drifted. So that infrastructure we've also built. And there are good companies out there that also, let's say, have this similar solutions to infrastructure and governance of these models. So that was kind of it was because of the problem that we did it. And now here 5 years later that we have solved a lot of this and we know how to do it. And then the grant money has run out, and then nobody continues to fund us because now it's, let's say, more clinical implementation science and validation of that, and not necessarily academic exercise, which I was in charge of. So to some extent, it was a very successful journey, but it also killed us. We killed ourselves in the success, if you can use that word.
Yeah.
And we are now coming with the large language models on top of this. So the next generation, first and foremost, needs to be grade 3 of the MDR, which is high risk. So that's in 2027. We have to comply to that. And then secondly, we can actually begin to make reports and automatic reports that describe, for instance, fracture site, fracture information, and then draft a report that you then can approve. So we are becoming more and more in, let's say, a full circle autonomous, let's say, reading methodology, but we're not there yet. There's still a lot of obstacles to go over.
That's a very good insight. Let's take this as a final word. So you mentioned large language models, which also Bastien has mentioned, and also we all know the new buzzword is agentic AI that takes it all together, and there are pipelines of different AIs working together. And I think this is what we will see over the coming years. So Michael, thank you for being with us, and thank you all for being here. Also, thank you our man in the background, Asif, who was switching gears, helping with the video projection, with the comments. And all of you enjoy your Saturday. Our next live stream is Sunday next year, maybe on X-rays only, as we have this series. So thank you all for being here, for celebrating this anniversary today, and enjoy your day. Thank you very much. Bye-bye.
Thank you.